and welcome everyone for tonight's show for the Just Ask from the EAO channel. Tonight, it's such a super pleasure because I am hosting a top-notch expert and a very nice person. And it's my real pleasure tonight to do this online seminar with Professor Martina Stefanini. Martina, I am hosting this show now for many times, but this is actually the very first time people keep calling me up and telling me, are you doing that show tonight with Martina? Please ask her one very distinctive question about harvesting and so on. That's the first time that happened to me. So you are a true rock star. Welcome to tonight's show, Martina.
Thank you, Stefan, for inviting me. I'm really happy to be with you on the stage tonight and to answer all your questions.
Yeah, we already have a lot of people logging in from all around the world. So I am logging in from Germany, you're logging in from Italy. We have Victor here from Moldavia. We have Oscar from Chile are also logging in. We have people from Austria, from Vienna logging in. So great, just share with us where you're from, share with them your thoughts, share with us your questions. Just to quickly introduce you, Martina, everyone knows you. You are really a rock star here, and you are from Italy. You are a researcher at the University of Bologna. You obtained your PhD. You are a lecturer, and actually we all know you from your textbooks. We all know you from the studies. We all know you from the collaboration with Giovanni for implementing a lot of techniques. Wrote a lot of books, travel all around the world. You just told me where you're from, where you're going into, coming from India over to Brazil and so on. So thank you very much for finding that time for us tonight. And of course, as it is my show and I'm hosting the show, I had to ask you this question. So your question tonight is, how are you harvesting connective tissue today? Again, a very warm welcome to you, Martina.
Thank you very much. Thank you very much. And I think that you selected a really nice topic, and we can discuss a lot about it.
Yeah, I'm also looking forward to that. And I already have these 2 or 3 questions from my friends in my back. So if no one asks a question, I think we're already good for, for the whole format. Martina, actually a case stepped by in my office today. And if you have a look at the clinical case which presented to me, like multiple gingival recession, I think you know that type of patient which we see there, a young female, very small and very fragile tissue. And now my question comes to my mind. Do you think that the sort of harvesting, not the technique which I'm using there in the front, but the sort of harvesting, what kind of tissue I'm using, makes a difference in that case? What do you think? Just quickly.
Just quickly, you present me such a difficult and tough and interesting case that we can discuss until midnight, I think. I think that in this case, since we have to use a connective tissue graft under a flap, the quality of the connective tissue graft that we are going to use to solve this case, anterior lower mandible, it's of paramount importance, the quality. So you ask me not about the technique, but my answer is what is important independently from the technique is the quality of the connective tissue graft that you are going to use and to apply under your flap.
Wonderful. So actually, my question that I asked you was exactly the right one, right? I think I learned a lot from your textbooks. That's why I asked you that question. So we have a lot of people logging in. We have Jose from Spain logging in. We have Tamer from Saudi Arabia logging in.
EAO family, it's so huge. It's amazing.
Amazing. So we have people from United Kingdom, London logging in. And with this, I don't want to delay too much. People don't want to see me, they want to see you. So Martina, please give us maybe some background, some insights. I know you prepared a short lecture and you agreed that I can maybe interrupt you at some point in time to ask you a question. So the stage is yours. It would be great if we could see your presentation.
Thank you. Thank you. I prepare my presentation, try to, let's say, just make a small background, I set up the background for the discussion that I really would like to have with you, because my topic is how I harvest today the connective tissue graft. And I think that we have to make some consideration regarding three main aspects. From one side, we have to do some anatomical consideration. Then we have to take into consideration the patient perspective, the patient-reported outcome when we speak about harvesting technique. And the last one, but not for importance, is the quality and the quantity of the graft that we need in our surgical procedure. So the first important aspect is anatomical consideration. When we think about palate, we have to think about how to reduce as much as possible complication in relation to the palatine artery. And so we have some nice article from the group of Lorenzo Tavelli. This is a systematic review that gave us some guidelines regarding the so-called safety zone. But this is a systematic review. And as you know, it gives us some numbers that derives from average data collected from a lot of articles that gave us some numbers. And in this systematic review, especially in the second schematic drawing, you can see that there is an average of called safety zone at the level of the molar, which is around 10 millimeter, 2 millimeters, starting to evaluate this dimension at 2 millimeters apical with respect to the gingival margin at the level of the palatal artery. Then, as you move toward the frontal area, the safety zone reduces because the trunk of the palatal arteries divided in different branches, and some of the branches takes a direction which is more coronal and more close to the gingival margin at the level of the premolar and at the level of the canine. So we have to bear in mind these general parameters and apply these parameters in our specific patient, because these were average data, mean data. So we have to check always our patient, because we can have a patient with an high palate in which we have a 17 millimeter distance from the cemento-enamel junction to the palatal artery, or we can have a medium type palate of patient or a shallow palate in which we have only 7 millimeters of safety zone, of not safety, of distance between the cemento-enamel junction and the palatal artery. So in every patient, my recommendation is to check the anatomy of the palate, to check the position of the palatal artery foramen with your finger, check which is this area, and try to stay as much as possible in the hard portion of the palate, in which you have less risk to make some damage to this artery. And when
Martina, can I ask you one question immediately?
Yes.
With the palatal artery, we sometimes hear the rule of thumb: if you stay mesial to the first molar, nothing can happen. I mean, not nothing, you know what I mean.
This is not true from one side, because as you can see in this schematic drawing, the branches of the palatal artery are more coronal into the anterior area of the palate. But if you stay mesial to the first molar, in case of arterial injuries, you have enough space distal to make the suture to stop the bleeding. Because the problem is, if you make a palatal artery damage at the level of the second molar, you don't have space for the compressive suture that will block the bleeding. So it's a technical problem.
And do you also think that if you are in the first molar area, the artery has already diverged so much that maybe a bleeding is not so major anymore, or is that just in theory?
I don't know if it is just a theory. What I can tell you is that I think that there is really no danger if you are in the hard portion of the palate. It's very easy to detect the hard portion of the palate and the soft tissue of the palate. Okay. So if you stay coronal to this line that is clearly visible, especially when you perform the anesthesia, I don't think you will face some real problem with the palatal artery. But I want to underline this aspect also during the description of the possible harvesting technique that we have. And basically, we can divide in two types of technique. We have the technique that ended up with a primary intention type of healing, and the technique that ended up with a secondary intention healing. And basically, the first technique that has been proposed is the so-called trapdoor technique, in which we have 3 incisions, 1 horizontal and 2 vertical releasing incision. We have to elevate the split thickness flap on the palatal side in order to get access to the remaining underlying connective tissue graft. And once the connective tissue graft is removed, we can easily close the door and obtain a first intention wound healing. The problem with this technique was related to the possible necrosis of the primary flap. And so with this idea, the L technique has been proposed, because if you reduce the number of vertical releasing incision, you increase the vascular supply to the palatal flap and you reduce the risk of palatal necrosis. And so the L technique has been described and then even modified in the famous, and let's say probably nowadays most used technique, which is the so-called envelope technique, in which there are no vertical releasing incision, only a tunnel on the palatal side that allow to harvest the underlying connective tissue graft. Which is the problem with this technique? With the trapdoor technique, we open a flap, so with 2 vertical releasing incision. So in order to harvest, let's say, a connective tissue graft of 4 millimeter height, you have to extend the vertical releasing incision 1 millimeter more apical in order to get access to the underlying connective tissue. And 1 millimeter is not such a big deal. But once you start to reduce the number of vertical releasing incision in the L technique, for example, in order to be able, only with these 2 incisions, to harvest the desired dimension of the connective tissue graft that you have to harvest, you need to extend more apically into the palatal vault your incision of the palatal flap in a blind way in order to be able at the end to harvest the final amount of the graft that you need. So as you can see in this technique with your blade, you have to go blind, more apical with respect to the final dimension of the connective tissue graft that you need. And for example, in the treatment of gingival recession around teeth, I usually harvest in the upper jaw a connective tissue graft height of 4 millimeters, not more, while in the lower incisor, like in the case you showed me before, the height of the connective tissue graft is between 4 and 6 millimeters. So what does it mean? It means that I have to harvest to treat the gingival recession of your case, and I need a connective tissue graft of, let's say, 5 millimeter height. With this L technique, I need to extend my intervention into the palatal vault 2 millimeter more apical and more distal with respect to the dimension of the graft that I need. And this is even more if I don't have vertical releasing incision at all, because in order to harvest my graft, to be able to detach it from the palate, I need to extend in a blind way, in an apical direction toward the central portion, toward the soft palate, 3 millimeters with respect to the dimension of the final graft that I need. And so in the schematic drawing that I showed you before, if you have a flat palate and you need 5 millimeter height connective tissue graft and you need to extend 8 millimeters into the palate, your incision, you are already outside the safety zone. And so I think that this aspect is really to be taken into consideration. So these are important aspects, but as I told you, we need also to take into consideration the patient perspective. Because when we speak about palate, I think that the patient perspective is of paramount importance. And this is also why we are trying to find some connective tissue graft substitute in order to reduce as much as possible the need for a second surgical site. And why I'm working a lot on that, because I really would like to reduce as much as possible the invasivity for my surgical procedure. And so what we try to understand is what is the most important aspect that is related to the post-operative pain for the patient. And in this randomized controlled clinical trial, we have compared 2 types of surgical approach on the palate, the trapdoor and the free gingival graft with the desepithelialization in a second stage. And basically, what we realized in this study is that the pain was not related, as we commonly believed, to the type of wound healing. It's not related to the primary intention or to the secondary intention type of healing. It's related to the depth of withdrawal. The more you go deep into the palate, the more the patient will have pain and difficult post-operative phase. And this is of paramount importance because we commonly believe that the type of healing is related to the pain, but the pain was evaluated through the painkiller assumption by the patient, increased by increasing the height of the withdrawal and by reducing the residual soft tissues covering the palatal bone. These were the 2 main important aspects related to pain perception.
Martina, I have again a question. It's a very nice presentation. The removal of the connective tissue in your studies, but also in your examples, is that always with a double split procedure, meaning you have the upper flap and then you split out the connective tissue? Or are there any reasons when you are harvesting this connective tissue with its periosteum?
No, usually I try never to harvest the periosteum. I try always to, in our technique, in the free gingival graft and desepithelialization in a second step.
That's clear.
Yeah, you are so superficial with your harvesting procedure that the periosteum remain always in position protecting the bone. And in particular, if you have medium or thick palate, you also leave some amount of connective tissue covering the periosteum and protecting the bone. The problem is when you perform a technique like the trapdoor in a thin patient phenotype palate patient.
Or maybe more also in a molar area. There are sometimes overhangs of bone. I actually had this today. In the first, second molar, you sometimes have these small overhangs and you reach bone with your blade.
Definitely. It happens also with the free gingival graft and disepithelialization in a second step, because sometimes it's so thin, the palate of the patient, that even if you stay only with the blade parallel to the bone, trying not to touch the periosteum, sometimes you have some bone exostosis that you have to overcome it with the periosteum elevator, otherwise you will make a perforation and the bone will remain exposed. And this case will be obviously associated with a worse post-operative in terms of pain for the patient. But as a general rule, I think that the main goal is try to maintain the periosteum covering the bone, and when it is possible, also some layer of connective tissue protecting the periosteum and the bone. But this is possible only if you are performing a technique in a patient with enough thickness. But if you don't have thickness, if you perform an envelope technique or a trapdoor, you have to save, because as I'm showing you in the next slide, you have to save some amount of connective tissue in the flap, in the primary flap of the palate, even if it is an envelope or a trapdoor, but you have to save some amount of connective tissue in the inner aspect to avoid the possibility for flap necrosis. That in our study has been demonstrated the worst event in terms of patient report and outcome for the patient, because if you have palatal necrosis, the patient has to, in our study, assumed more painkiller with respect to all the other patients in our article.
And even more, it's advisable to stay away from the periosteum, because you showed in your work that the quality of tissue just over the periosteum may also be not so good, right?
Yes, the quality, this was the in relation to the pictures of one of the cases included in our study, in which, as you can see, after 1 week after the surgical procedure, there was this area of necrosis because we were forced to thin a lot the palatal flap, because the palate was not thick enough to allow at the end to harvest the needed thickness for the connective tissue graft. And in that case, you thin too much the palatal flap and you harvest the underlying connective tissue graft, maybe also using the periosteum elevator and removing the periosteum from the bone. And in this case, the patient has the worst postoperative course.
Yeah.
And as you asked me just now, another important aspect is the quality of the connective tissue graft, because the more you go deep into the palatal fibromucosa, the more you can have fatty and glandular tissue. And this was another systematic review and meta-analysis that conclude that the free gingival graft and disepithelialization in a second step can be considered evaluating from a clinical point of view the outcome in terms of coverage, keratinized tissue gain, and soft tissue thickness. The connective tissue graft deriving from the free gingival graft and disepithelialization in a second step can be considered the technique of choice for recession coverage. But regarding that, I would like to come back to your question and showing you the aspect of the quality and on the other side of the quantity of the palate. Because when you perform anesthesia and you make your injection, you always have the feeling that you have more thickness at the level of the premolar with respect to the molar area. And if you look at these two examples, the stop is at the same level. And as you can see, there is a huge difference in the same patient in terms of final amount, in total amount of thickness of the palate at the level of the premolar and at the level of the molar. But the problem is the quality of these two tissues, because at the level of the premolar, you have a lot of fatty and glandular tissue. So if the amount of thickness in total is, let's say, 5 millimeters of soft tissue thickness, but you have 3 millimeters of fatty and glandular tissue, it means that the remaining two are connective tissue and epithelium. Epithelium, which is even thicker in an apical direction because you have the palatal ruga at the level of the premolar, which are invagination of the epithelium, not only on the external aspect, but also in the internal aspect. So when you perform the desepithelialization, if you perform a free gingival graft and desepithelialization in a second step at the level of the premolar, the desepithelialization should be done more deep because you have to be sure to remove all the epithelial cells derived from the palatal rugae in this area. While in the molar area, you have a reduced amount of thickness with respect to the anterior area, but the quality is completely different because if you have only, let's say, 4 millimeters, 3 of them are good quality of connective tissue without glandular and fatty tissue. And so if you think about the surgical technique and you think about harvesting in the premolar area in a patient with a reduced thickness, you have to keep some connective tissue in the flap or in the envelope in relation to the technique that you are going to use. And then you have to harvest a small portion of connective tissue that remain and a lot of fatty and glandular tissue. So you will end up with 1.2 millimeters of connective tissue thickness, but the connective tissue is only 0.3, 0.4. The remaining portion is fatty and glandular tissue. And what happened to fatty and glandular tissue during the healing? It shrinks. It will shrink. So you will not obtain the final good increase in soft tissue thickness in your patient during the healing. So the quality of the graft has a huge influence on the final amount of your surgical procedure. While if you harvest in the molar area with the free gingival graft and desepithelialization, you harvest the superficial portion and you have always in, let's say, 99% of the patient enough thickness for this type of technique. Why?
So Martina, I have a polemic question now. So is there any reason for harvesting not with the deepithelialized technique in the molar area?
Don't ask to me. I don't know. I don't. From one side, I can tell you also because it's an easier technique. Yeah. When you are on the palatal side, it's so easy to harvest the free gingival graft. While in truth, if I'm trying to do an envelope technique, it's much more difficult. It's time consuming. So I don't know why. I can tell you that on the other side, an aspect that should be taken into consideration is related to the desepithelialization, because desepithelialization is not so easy at the beginning. You need to, let's say, have your learning curve in order to be able to really remove all the epithelial remnant on the surface. And for example, a lot of people ask me the same question: why you cannot do the desepithelialization on the palate using a diamond burr? And in truth, I can tell you that when you use a burr on the palate, even if you have a lot of saline, there is always the risk to make some area in which maybe you go a little bit more deep and you make some, let's say, necrosis of the connective tissue that you are going then to harvest and place on the gingival recession that you showed before. So I usually like to do it with my blade in a second stage because it's less traumatic for my connective tissue.
That was actually the question people asked me. Ask Martina, how is she doing that? I don't know if she's going to show that in your lecture, but how can I make sure that there's no epithelium left when I depithelize it extraorally?
I don't have in my presentation because I don't think it was so technical.
So tell us.
But yes, but there are 3 rules. The first rule is always to change the blade and have a new blade. You don't have to use the same one for the harvesting on the palatal side. New blade. Then you have to use a non-slippery surface above which you have to stabilize the connective tissue graft with your finger. Don't use the tweezers, that seems more fancy. Fingers is the best way to stabilize the connective tissue graft. Then obviously magnification.
That could be a gauze pack or what would you recommend? A non-slippery surface?
Yeah, it could be simply a surgical cloth, which is not on the plastic side but on the other one. Or maybe you can also use, the instrument that the pediatrician used to check the throat of the kid, the wood stick.
Yeah, okay.
This one can be also a possible surface because it is not slippery.
Or the beard of the patient? No, that was a joke.
I always ask my patient to shave before because otherwise with the suit it's a nightmare.
That's true.
I prefer female patients.
Very nice. Yeah. Okay, rule number 2 and 3.
Yeah. And then magnification. I don't use microscope. I use only magnification. But with magnification and the drop of saline and the light of the chair perpendicular to the connective tissue graft, you can very well distinguish the area in which you have some epithelial remnant because connective tissue and epithelium reflect the light in a different way. And once you remove a slice of epithelium, because the problem is that you have to remove a uniform slice of epithelium, because if you keep the blade just like this and you make a peeling, you don't see this difference. You have to remove a slice, and then you can see very well that close to this slice, there is still epithelium. And so you remove it. So these are the main rules.
Do you think something could happen if you leave remnants? I mean, of course, not huge epithelium, but remnants?
No, I don't think that nothing happened. The worst thing that can happen is to have the formation of this so-called epithelial cyst. With the epithelial cyst, what happened? Sometimes the patient, if the epithelium cannot find the way to make a small, let's say, it looks like a fistula, but it's not a fistula, and it comes out a liquid which is not pus. It's not like yellow and dense, but it's like water that comes out from this small fistula. And usually, if you squeeze it and you ask the patient to use chlorhexidine at home, chlorhexidine gel, and gently squeeze, within 1 month, it completely disappears. But if at the beginning, it is not able to create this like fistula, the patient can come with, let's say, some swelling. And you say, okay, what happened? But if you make a small perforation with a very, very small needle of the anesthesia, then from this perforation, you can see that the liquid start to come out. And again, within 1 month, maximum 3 months, it is completely solved without any type of problem. Yes, obviously. If you don't remove the epithelium, you will have a pocket formation. But
Sure.
Usually the amount of connective epithelium that remains after the disepithelialization under magnification is really small. One suggestion that I can give to, let's say, non-skilled surgeon can be to harvest at the beginning, if it is possible, a thicker graft, a thicker free gingival graft from the palate, so you can feel more comfortable in remove the slice of epithelium. Because if you already have a very thin free gingival graft, you are scared to remove too much epithelium and remain with nothing, okay? While if you have a thicker amount, you are more relaxed and you can remove your slice like with the sushi.
Yeah, and probably when it comes to mobility, it doesn't make a big difference, right?
No. And at the beginning, if you have to take into consideration the final outcome of the surgery and the slightly worse post-operative course, I think that the balance is toward the best post-operative outcome. And another important aspect is that before doing the disepithelialization, I always check the inner aspect of the free gingival graft. If there is fatty and glandular tissue, I remove first fatty and glandular tissue, because otherwise when I turn my graft to do the disepithelialization, if there is fatty or glandular tissue, this tissue are not stable and does not allow me to maintain stable the graft. It becomes slippery because of the fatty and glandular tissue that is in the inner aspect. So always start from inside, removing the fatty and glandular tissue, and then perform the disepithelialization. And yes, so this schematic drawing show you exactly what I mean, the difference between the quantity and the quality, which is of paramount importance. So we recently published this narrative review in which we described the possible complication related to the palatal soft tissue harvesting, and we have compared the possible risk for intraoperative complication and postoperative complication with the technique that consists on the trapdoor, on the envelope trap, with the free gingival graft. And as you can see in this final table, we have more intraoperative risk with the technique that provides the subepithelial connective tissue graft, because you have higher risk for artery injury, so more risk for bleeding. And this is because, as I told you, you have to extend, for example, with the envelope technique, 3 millimeters more apical with respect to the final dimension of the graft that you need, so you can have some risk of palatal artery injury, and in this case obviously of excessive bleeding. And there is the risk also to have an inadequate graft size, because if you are not able to extend your incision more apical with respect to the final dimension of the graft that you need to harvest, maybe you ended up with a 2-3 millimeter high connective tissue graft instead of the 4-5 millimeter that you need. And with this type of technique, you have a higher chance to harvest a connective tissue graft rich in fatty and glandular tissue, because you are more deep into the palate, so you are more close to this portion of the palate. In the post-operative phase, you can have, let's say, some complication in terms of bleeding increased in the free gingival graft group, because since the patient has this area of secondary intention healing, if, for example, for mistake, the patient chew in the surgical area, it can start to bleed on the palatal side. But usually it's a complication that's solved by itself. I always give to my patient some sterile gauze and a vial of tranexamic acid. And in case of bleeding, they simply have to put the tranexamic acid on the gauze, compress on the palatal wound for 4 or 5 minutes, and usually it's completely solved easily by itself. What we have highlighted in our study was that there was no difference in terms of pain. The difference in terms of pain was against the subepithelial connective tissue graft because of the depth of the withdrawal. But the only thing that the patient reported against the free gingival graft was that they, let's say, has, more discomfort in feeding habits. Maybe because the patient is more worried when he knows that he has an area of secondary intention wound healing. And so this is, let's say, the major, let's say, aspect against the free gingival graft that we found. So basically, I can tell you that when you harvest a connective tissue graft deriving from the disepithelialized graft, you have an easier technique on the palatal side. You are able to harvest the connective tissue, which is immediately subepithelial, which is of the best quality, without fatty and glandular tissue, that is stable, collagen-rich connective tissue of the best quality, with the less depth of withdrawal that is strongly associated with the post-operative pain and with the quality of the connective tissue graft, and you have the possibility to adjust the thickness of the graft, as I told you before, because you don't have to maintain the thickness on the palatal flap, and so you can also harvest a thicker free gingival graft and then adjust the thickness in relation to the case that you are treating, having the right quantity of the graft thanks to the surgical technique. While when you perform a subepithelial connective tissue graft technique, the only advantages, which is not related to the pain, but to the comfort for the patient during the feeding habit, is the fact that you have a primary intention palatal wound healing. So your question was,
Martina, why? Which just one more question. The primary wound healing, I mean, it is a primary closure. Let's put it like this. It may not stay a primary healing, because if I look at my harvesting procedures in the palate, I mean, not all of them are really staying closed, right?
Yes, definitely. And then if you have the necrosis, it's worse than a secondary healing by itself. Because
and then the best tissue is necrosing.
Exactly. So what you can harvest with the free gingival graft, you can harvest such a stable connective tissue graft in which you can write ciao to you and to the audience with the connective tissue graft, because the quality of this connective tissue is so stable and so dense and so white, because it is made of collagen fiber. And this is especially in the case that you showed before, it's really of paramount importance, because the role of the graft in the lower anterior mandible is not only to help the flap to remain stable in the coronal position, like in the upper jaw, but is also to act as a barrier to prevent early muscles reinsertion, because in this area, as you know, we have a lot of muscle. We remove also these muscles in our technique for the treatment of lower anterior recession. And you need a stable barrier of connective tissue that should be dense and the best quality, because otherwise it will be not act in this indication. And so the quality is really of paramount importance. If you think also about implant, when you have to increase the soft tissue thickness, you have to reach a thickness of 2 millimeters between the flap and the connective tissue graft. If the quantity of connective tissue in the connective tissue is not enough, you don't reach this increase, the final increase of 2 millimeters. And what happened? You can, for example, still see the transparency of the implant abutment component. So it is of paramount importance, the quantity and the quality of the connective tissue graft.
Martina, it was amazing. A great presentation. I learned so much. I'm still thinking about so many things. But the only thing I'm very glad that you didn't write Auf Wiedersehen in German with connective tissue
It's
graft.
too much also for the pre-gingival graft.
No, I'm kidding. So it was amazing.
Next time I will do my best.
Okay, fantastic. We have a lot of people logging in from Argentina, from Chile, from Pakistan, from Syria, probably all the countries you travel to. And there are a lot of questions. And actually, I would like to ask some of the questions. We definitely will not manage to make all of them. There was one question from Turker, and he asks you if you sometimes decide to leave a piece of epithelium on the connective tissue, like sort of for an envelope in a recession coverage area. You see, leave it intact, or doesn't that make sense?
Yes. No. I know this technique, but I don't think there is a true advantages in this technique, because what I like when I'm trying to treat a gingival recession is not to have the connective tissue of the graft exposed, because I want to left the connective tissue completely covered by my flap, so completely desepithelialized, because in terms of the aesthetic, it's much better.
But what would you do in cases of a small amount of attached mucosa?
This is
no, it gets difficult. The later the hour, the difficulter the question.
No. It's a huge topic, but I will try to summarize as much as possible the concept. Okay. What we like of the keratinized tissue is not the external characteristics of the keratinization. We like the keratinized tissue because in the inner aspect there is connective tissue, while we don't like alveolar mucosa, not because because for me alveolar mucosa is female, but not because she is not keratinized on the external aspect, but because she does not have in the inner aspect the connective tissue. Yeah. So when we cover a recession without any keratinized tissue at all remaining apical to the gingival recession, and we move coronally a flap made of alveolar mucosa, and we put in the middle between the root and the alveolar mucosa our dense connective tissue graft, we change the characteristic of the alveolar mucosa, and the alveolar mucosa remain non-keratinized in the external aspect, but has the same mechanical properties of the keratinized tissue because there is the connective tissue from my harvesting procedure. So I have an aesthetically nice area with the alveolar mucosa, but at the same time, the same mechanical characteristics of the keratinized tissue, which is the stability.
And that's why it's even more important that the quality is good, right?
Exactly.
Okay, I'll get it. I'll have it. There's another question from Robert. Hello, Robert. How do you protect the wound on the palate? I mean, you already talked about tranexamic acid. Is there any stent you're doing, or what you're doing on a general basis?
I have to tell you that in the past, I used to make suture on the palate immediately after the harvesting procedure. Now I change because I realized that the most important thing is to reduce as much as possible the surgical time on the buccal aspect in order to reduce the swelling in the post-operative phase. So usually I harvested the free gingival graft. And during the desepithelialization, my assistant is compressing a gauze on the palatal side. Then, before suturing the connective tissue graft, I remove the gauze and I check on the palate. And usually it is not bleeding anymore. So I fix my connective tissue graft, I close my flap, and then I come back to the palate. If it is not bleeding anymore, I usually only apply a fibrin sponge and I cover it with the layer of cyanoacrylate. And that's enough. If there is still some bleeding or the depth of the withdrawal was high because it was a connective tissue graft for implant treatment, for example, I place a fibrin sponge, I make compressive sling suture around the involved teeth on the buccal side, and I placed on top cyanoacrylate. In the past, I used the periodontal dress, but now I don't use it anymore because it protect the wound, but once you remove it, there was a lot of bacteria inside, plaque accumulation. I don't like it at all anymore. While if you cover the fibrin sponge and the suture with the cyanoacrylate, it's perfect. It improves the stability of the blood clot, and it's when you see the patient for suture removal, it's everything very, very clean without plaque accumulation. I don't make stent. I'm working almost full time at the university. We are poor at the university, so we don't have the possibility to make the stent and to have the cost of the stent for the patient who comes to our university. So I don't use it. I think that if you have the possibility, can be a good option for patient, but it's not at all mandatory.
Okay, wonderful. I wonder, I mean, so many expensive sports cars come from Italy and you don't have the money for making a stent? No, I'm kidding.
We have money for football in Italy, but not for university.
Martina, it was just wonderful. There are so many still questions there, but actually time has already passed. And you know what that means? We have to get you back here. So yeah. I'm sorry for that. I will have to invite you again here. There's so many people like applauding for your lecture, like Oscar saying, amazing presentation, Jill saying, congratulations, Martina. We're from Turkey. Thank you. Great. Everyone great. Perfect. So Martina, for me, it was a great pleasure. I learned a lot. Actually, I will change a lot of things, to be honest, because I think you changed my mind in different things. Although this is the thing I've been doing for 20 years, also in research and clinic, it was just amazing. So thank you very much from side of the EAO, but also from my side and all the participants. Thank you, Martina.
Thank you very much. Thank you to the audience. Big hug to all of you all around the world. And see you next time. Waiting for your invitation.
I will. There are just two more things. We have the EAO annual congress. We'll probably also see you there, Martina, in Milano. The abstract deadline or the abstract commission is already online. So if you have a scientific project or whatever, that's how we also started, Martina, right? Just send it there. Have a poster there, have an abstract. Also have a look in the YouTube chat and in the description at the bottom of this YouTube thing. There are many educative programs from the EAO. Some of them also Martina is involved. We are involved. Just check out whatever you can do. With this, I would say good night, good morning, and wherever you are, and to you, Martina.
Milano, for sure. Yeah. We are happy to welcome you in Italy.
Absolutely. So with this, thank you very much again. Thank you, Martina. It was great, amazing. We will have you back. It is a decision now from me. With this, ciao in the round. Thank you again. Have a good night, have a good day, and see you next time. Ciao.
Ciao.